Just gonna ask everybody go on mute. So right now, this is what are we? We are in week 5 of Broker Academy. We're gonna go over Medicare Part D plans. So I'm gonna start by sharing my screen. And again, everybody, this is your time. If you have any questions, feel free to interrupt me. And again, this recording will be on the agency website. If you don't have access to the agency website, let me know, reach out to me. All right, here we go. So we're at screen 2. And let's go to the PowerPoint presentation. And we'll start off, we'll use this one. So here we are, Medicare 101 prescription drug plans. Let me see, are you seeing my split screen or the whole screen? Let me see how I can change that and just do one screen. Oh, somebody's in chat already. Split screen. All right. Let me stop sharing. Screen 1. Let's try that. All right. Now, is that the full screen or the split screen? That looks like it's the full screen. All right. Perfect. Here we go. All right. So we already know this chart. I show it all the time. How do we help somebody out? Well, we help, and I say this every single training. There's going to be a lot of redundancies, and the reason why is everything that we repeat is something that you really need to know. It has a huge impact on what we do and why we do it. So one of the things we do is we help people get their Medicare A and B. We go through socialsecurity.gov, help them apply. Now, again, all the rules with Medicare A and B, you do not have to go on it if you have employer coverage. Once you turn 65, if you have credible coverage, you can wait. You can wait till you finally retire. At that point, you can get A, B, or B if you didn't delay it. Other things to keep in mind, if you are already taking Social Security at age 65, you'll automatically get A and B. So if it's a situation where a client does not want it, they check the box, return the mail back to Social Security saying that they want to delay it. So with A and B, they get about 80% coverage on all their medical costs. What we're trying to do is figure out how we're going to get that remaining 20% coverage, either all of it or as much as we can. That A and B does not cover RX, and that's where we're going to focus on the prescription drug plan. And just like every other CMS plan, the person must live in the service area. So we're going to be talking about prescription drug plans. So you see at the bottom, step 2, there's option 1. If somebody wanted to take the supplement route, which we talked about last week, Medicare supplement plans do not have prescription coverages. So they have to have a standalone Part D plan. If somebody decided to take option 2, which is the Medicare Advantage plan, if it's a Medicare Advantage prescription drug plan, MAPD, that drug plan is bundled with the medical. Okay, so we're going to go over 2 options. A standalone prescription drug plan and a Medicare Advantage prescription drug plan, they have the very same structure. Okay, so there's nothing different about the 2 of them. It's just that one is bundled, and we'll go into that in more detail. So the next screen, Medicare prescription drug plans, also known as PDPs. You're going to hear that acronym a lot. PDP, 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 prescription drug plan. Part D is in Delta, is your prescription drug plan. MAPD, remember, it's Medicare Advantage prescription drug plan are the ones with the prescriptions bundled. There are Medicare Advantage plans with no prescription coverage. We talked about this, I believe, in week 2. The reason behind that is there are some individuals who might have outside credible coverage for their prescriptions and they only need the medical. Case in point would be veterans who get their prescriptions at the VA. We did some great VA training last week. Judy G from Humana talked about the intricacies of working with veterans, but that's one of the reasons why we have that PD in parentheses. All right. Medicare prescription drug plan types. So you have the PDPs, If it's a standalone prescription drug plan, you will have a monthly premium in most cases. In Florida, there were some PDP plans, I think last year through WellCare, that were zero premium, but it is a separate drug coverage or a separate insurance coverage. Since it's separate, there is going to be a premium. So keep that in mind. It's separate from medical coverage. With the MAPD, some of them have zero premium because it's attached to the prescription drug plan. Okay. And it, again, bundled with a Medicare Advantage plan. And one of the rules, you cannot have a standalone prescription drug plan or any sort of Medicare Advantage plan or MAPD plan at the same time. They will cancel each other out, all right? And vice versa. Enrollment periods. So they're going to be all the same that we're used to in those previous enrollments. The only one that's going to be different is, well, actually, it's going to be relatively the same. You have annual election period, which is October 15th through December 7th. That's the free for all. That's when somebody on a Medicare Advantage plan or a prescription drug plan, they can make as many changes as they want. And the last application that is received on December 7th or by December 7th will be the one that takes effect January 1st of the next year. All right. Open enrollment period, OEP. This is January 1st through March 31st. Now, keep in mind, OEP is different. Only somebody who is in a Medicare Advantage plan can take advantage of this enrollment period. They can either go from one MAPD to another MAPD, or they can go from an MAPD to a standalone prescription drug plan and then take on a Medicare supplement plan. So they do have those options. The way it would work is if somebody submitted an application in January, the following February 1st, the new plan will take effect. And it goes down the road. If they did it in February, it would take effect in March. If they did it in March, it takes effect in April 1st. They can only make one change during that period from January 1st to March 31st. Now, if somebody has a standalone prescription drug plan, they are locked in. They are not allowed to use the OEP special election period. That is just for people who are in Medicare Advantage plans. Let's see. These are all the standard enrollment periods. You have a change to, you have a chance to get other coverage. So you're new to Medicare. You've left your employer. You've already had Part A and are going to be enrolling in Part B. You had prior Medicare, and now you're turning 65. Remember, there are individuals who are on Social Security disability that after 24 months, they get their Medicare coverage. Your plan changes its contract with Medicare. I lost the coverage because Medicare ended its contract with my plan. I received a letter from Medicare saying I can join another plan. So there's going to be some plan terminations. There is a plan down in Georgia. They are going bankrupt. So they have until the end of October to get into a new plan for the end of the year. So that's going to be the special election period. That's going to filter into AEP. So there are changes. It does happen. It's not common, but something to be aware of. Special needs plans. We talked about this 2 weeks ago. If anybody applies for the Medicare Savings Program, if they get approved, if they get a higher level, or if their level's reduced, they get a special election period. 5-star plans or any sort of FEMA disaster, that could create some sort of SCP. The bottom line is there's usually a way to help somebody out in most cases. So if you have somebody who's kind of in a jam, you can run it by Tracy or myself and say, and ask, is there something that we can do? Can we move them into another plan to help them out? So it's not always 100%, but we'll give it a shot. All right, prescription drug stages. So the first stage is the deductible. Now, keep in mind, not every single prescription drug plan will have a deductible, but if it does, the maximum, the deductible can be as $590. So your deductible, think of it as car insurance. If something happens to your car, you have to pay that money first. before the insurance kicks in. Very similar. If the plan has a deductible, you might have to reach that $590. Now, if you have a very expensive drug, you might reach that deductible and go through all the stages the very first month. After the deductible's met, you have the initial coverage stage. This is what we're all used to, where you go to your pharmacy, you have a prescription, you pick it up, it's $5, right? Or it's a percentage of the entire cost. This is the initial coverage stage. And the copay and coinsurance are based off of the tiers. We're going to talk about that. Each insurance plan has up to a minimum of 4 tiers, but some actually have them up to 6. We'll go into that. Catastrophic coverage. So once the total out of pocket, which would include the copays and coinsurances that your client pays, in addition to any sort of extra help they're getting from the manufacturer, once that combined amount reaches $2,000, 100% of their prescription costs are covered for the rest of the year. Now, that's brand new for this year. I know if you've been doing this for a long time, there used to never be a cap on prescription coverages where you would be paying for the rest of the year and it got really, really expensive. So there is a nice cap available. Then there's the prescription payment plan. The way that works is if somebody is going to meet that threshold of $2,000 almost within the first or second month of the year, they can sign up for a payment plan. They do that through the insurance company. They then get onto an installment plan with the insurance company, but every time they pick up their drugs, they don't pay for it. Okay. If you have any questions about that, we can jump into it a little bit more. All right, next slide. Medicare prescription drug tiers. Tier 1, and this is going to be standard across the board. Tier 1 is their preferred generic. Now, not every single generic is going to be considered preferred for every single plan. So that's where we actually have to do some digging and researching to find out where we can get the best savings for our clients. And this is going to reflect cost too. Tier 1s are usually the least expensive prescriptions out there. Tier 2 are just your standard generic. Again, they're a little bit more expensive than the Tier 1. Tier 3, preferred brand. Tier 4, non-preferred brand. Tier 5, specialty. Tier 6 are sometimes maintenance. And with maintenance drugs, if it's insulin, it's capped at $35 a month. But this goes in order of expense, except for maintenance. Usually maintenance are capped. All right. Here are terms you need to know. Formulary. Formulary is basically the encyclopedia of the plan drugs that are covered. What the formulary will show is it'll show the name of the drug. It'll show any sort of restrictions. We can talk about that, whether prior authorization is required, whether quantity limits apply, if there's step therapy. It'll also show the tier that the prescription is on. So the formulary is a great guide to help you with the presentation. Prior authorization, what does that mean? It just means that before somebody can get this prescription, the doctor needs to go to the insurance company and say, hey, listen, can we get this drug for our member? And this is why. So a lot of times prior authorization is required because there might be less expensive drugs available to the member based off of their medical condition. And the insurance company might say, hey, listen, why don't you try these lower cost drugs before we switch it over to the more expensive one. That's also called step therapy, and we're going to talk about that shortly. Quantity limits, depending on the drug. They might say, listen, you're only going to be allowed 30 at a time. We're not going to do a mail order. You're not going to be able to get a 90 supply. That way they can kind of keep track of the prescription and make sure that it's not really abused. Step therapy, like I said, it's an incremental increase in cost of a prescription The insurance company will generally like somebody to start off with a generic drug before they move them to a brand name drug. Again, with step therapy, the patient would work with the doctor would work with the insurance company. The member or the patient does not call the insurance company and say, hey, listen, can I get a prior authorization or can I get bumped up to a higher tier prescription? So just keep that in mind. And we don't do that either. We cannot call the insurance company on behalf of our client and say, listen, can you give them prior authorization for the drug? These are strict communications between the doctor's office and the insurance company. Part B drugs. So there are two types of drugs when it comes to Medicare. There, the Part D is in Delta. Those are the prescriptions that you pick up at the pharmacy and you take at home, or those are the ones that are delivered to you by mail that you take at home. But there's also drugs that you get in the hospital. Either they're infusions or injections. Anything that is taken or administered in a hospital falls under Part B. A good example would be chemotherapy. Again, that falls under Part B, which then goes towards the medical portion. If a Medicare Advantage plan, in most cases, the Part B drugs are 20%, you'd pay 20% of the cost. The amount of money that you paid for that prescription would go towards the maximum out of pocket for the medical portion, not the maximum out of pocket for the prescription. So you will get people who will say, wait a minute, I went to the doctor, I had an infusion, they're saying that I have to pay $300. Well, that might be the co-insurance, the 20% that they have to pay based off of it being a Part B drug. Preferred pharmacies. Every plan, for the most part, has a relationship with a pharmacy. Who knows what the relationships look like, but for the client, if they go to a preferred pharmacy, they usually pay less for their prescriptions than if they went to a standard pharmacy. An example of this would be CVS and Aetna. CVS owns Aetna. So if you have an Aetna plan, you go to CVS, you'll probably pay less than if you went to a standard pharmacy. So one of the things that we ask for when we're looking for Medicare Advantage prescription drug plans or standalone prescription drug plans, we ask, where do you like to get your drugs? Another thing that I ask, I say, where do you get your groceries? Trying to keep that convenience for our clients. If they're picking up their groceries, it might be really easy for them to swing by and get their prescriptions also. Mail order pharmacy. So a lot of your maintenance drugs, you can get them sent to you every 90 days. Sometimes it's at a reduced cost. Other times it's the same copay you would normally pay. You never pay more though. It's really convenient. And again, that's for maintenance drugs, ones that you're going to be on for the rest of your life. You wouldn't be doing a mail order for, let's say, an antibiotic or something short term. All right, Part B drugs in a hospital. Can it be outpatient or in a doctor's office? Yes, as long as it's administered by the doctor. All right, what do we have next? Low income subsidy, LIS. We talked about this 2 weeks ago. If somebody applies for the Medicare Savings Program in the state of Connecticut, they will automatically be enrolled in the low income subsidy, which is the federal program. We had Mary Lynch on there who actually worked with Social Security. She brought up a good point. For the state of Connecticut, do not have them apply directly to the federal program for the low income subsidy because their thresholds are much higher than in Connecticut for approval. So somebody who might get LIS through the state process through the Medicare Savings Program would probably be declined if they went straight to the federal program. So if you have questions about the Medicare Savings Program, reach out to me, reach out to Tracy, we can help you out. But the bottom line is if somebody applies for MSP, Medicare Savings Program, regardless of the level, whether it's QMB, SLMB, ALMB, they will get approved for low income subsidy. Okay. And that approval is locked in usually for 12 months. So what kind of happens is that somebody, let's say, had QMB, they go on to a DSNP plan, and for some reason, when they do their redetermination, let's say it's after 6 months, and they get kicked off the plan, that LIS will still be in effect for the remaining 6 months. It's behind the scenes, and that helps with the prescriptions. It would also help with the premium for the standalone prescription drug plans as well as the copays. Formulary exception. So Ed, we had a little a conversation about this. If a prescription is not in the formulary, you can ask for a formulary exception. We cannot guarantee that the exception will be made. And we can't ask ahead of time whether the insurance company won't let us know ahead of time whether or not they will grant that formulary exception. So it's kind of a situation where, hey, you have 10 prescriptions. One of them isn't covered by any single plan, but 9 out of the 10 are covered by this particular plan. It'll save you the most money. I cannot guarantee that a formulary exception will happen, but let's put you in the plan. Let's see what happens. If not, we have to find other alternatives for that one drug that isn't covered. Formulary exceptions need to be renewed every year. So I had a client who had one for Aetna. The drug was not in any formulary. Aetna every year would grant the formulary exception, but you can't take it for granted that it will happen the next year. So if you do come across that situation, the conversation is, look, this Aetna plan still makes the most sense. 9 out of your 10 prescriptions are covered. You have a formulary exception right now. There's a good chance that they're going to renew it next year. Let's move forward. If it doesn't work out, we'll pivot, we'll look at an alternative. Formulary exceptions are just like a prior authorization, step therapy. These are coordination between the doctor's office and the insurance company. Okay. So if a client gets nervous, hey, how does a formulary exception work? Just reassure them, your doctor's offices do this all the time. Okay. They're the experts. They'll take care of it, and we'll see what happens. Utilization restriction exception. This is where I wish Tracy was here. So this is where I think this is for, let me, I don't want to be wrong. So guess what? You don't have to be an expert all the time. I'm wondering if you could still see my screen if it's showing Google. Utilization, restriction, exceptions. Can be granted if the requested information is deemed medically necessary by the prescribing physician. Okay, so like prior authorization and step therapy, to prevent access to necessary medication. This exception process allows patients to potentially bypass these restrictions and receive coverage for a drug not normally covered under the plan rules. Let's see what CMS says. Tiering exceptions, formulary exceptions. But again, it's very much like health plans often use utilization management tools such as prior authorization. So it's just one and the same. It's an all-encompassing term. All right, so if I go back, and hopefully my screen is showing. Give me a thumbs up if I'm back on the presentation. Everybody's asleep. Perfect, thank you. The tiering exception. Basically, if I had a member who was on an Aetna plan, they had a drug that was not in the formulary. It was a generic, inexpensive drug. It probably cost 50 cents. But since it was not in the formulary, he needed to get a formulary exception. And usually formulary exceptions come in at a tier 3. So he would be paying significantly more money than the cost of the actual prescription. It was silly because he would pay that flat copay. He then applied for a tier exemption and they gave him a tier 1 on that formulary exception. Again, oddball situations. Good RX, benchmark plans. So benchmark plans are plans specifically designed for people who are on LIS. Anybody can be on them, but if somebody has LIS and you put them on a benchmark plan, those are specifically Medicare prescription drug plans. The LIS will cover that benchmark plan's premium. So in most cases, they won't pay for that extra coverage and they'll get help on the prescriptions. I do want to jump off of this presentation. I want to go into our agency portal. So Jesse Pito did a great presentation back on March 8th of 2024, where she talked about all the different discount programs. So there are ways of saving people money if they don't qualify for coverage through their Medicare plan, if a formulary exception isn't granted, if Medicare doesn't even cover the prescription. So you could definitely watch this video. There's another company called the Canadian Med Store. It's out of Florida, but this helps people with their prescriptions as well. We did a training on this. Let's go back to the agency website. We actually did it this year. Canadian Med Store, June 5th of this year, an hour-long training of how that all works. So that's another way you can help clients if their prescription isn't covered. The other standard way of doing it is GoodRx. Type it in here. Let's say Januvia. So hopefully I spelled that right. Not too bad. You type in Januvia. Oh, I got a question in here. Can't see your screen. Oh, let me stop share and let me share it again. Too much toggling. So here, I typed in Januvia and choose my pharmacy. I'm going to do it closer to home, 06477. So this gives me an idea of how much Januvia would cost. Right now, standard coupon, $558. If I went to Walmart, $299. So there are ways of saving people money. The other way is you can reach out to the manufacturer. The manufacturers have different policies, different rules. They change all the time. But what you could do is, if you really wanted to help, you could go into Google. You go into Google, you type in who makes Januvia. Merck. So, and here you could go on to the Januvia website. You can see if there's any way of helping your client. So there's ways of doing that as well. Keep in mind that if your member uses Canadian Med Store, if they use GoodRx, if they go to an outside manufacturer for an outside help, that does not go towards their true out-of-pocket for their prescriptions. It does not help them get to that $2,000 faster. So, you might want to you got to think of it in terms of the math and the financials. Yeah, if they go straight through the prescription drug plan, they're going to cap out at $2,000. That's it. Any other prescriptions for the remaining part of the year, they pay nothing. But if they go through, let's say, a Good RX in the Canadian Med Store, and they're paying, let's say, only $200 a month, well, again, $200 a month for 12 months, you've capped out. You've paid more than that $2,000. So we're going to show you how to look at this information in the quoting system, but just keep in mind that, just because going for the discount might not always be the best option because they have that cap at $2,000. So I'm going to share my screen again. And let's see, my presentation. It's not coming up for me. So I've been having problems with my monitor, so I apologize. Just do the main screen. This is screen 2. This should work. Okay, back to the original presentation. Really? Doesn't want to show my presentation. Let me stop sharing again. While I figure out this technical difficulty, if anybody has any questions. All right, let's try this again. All right. And we here, take a look. Let's click on this, actually. So this gives you an idea of what a prescription drug plan formulary looks like. Let me know if it pops up. Just give me a simple thumbs up. But this is going to be a Humana formulary. All right, perfect. Thank you. So here we go. Prescription drug plan, Humana abbreviated formulary. It's for 2025. Get rid of this. Let me see if I can increase the size. Maybe make it a little smaller. Can the formulary change? Tells you about that. It can in fact change, which is kind of stinks for us that they can make changes halfway through the year, but that's the way it is. We don't make the rules. Again, it talks about which drugs can be removed, what happens. If you want to read all this, this is great. This explains the tiering. Here you go. So we know that this plan has up to 5 tiers. Here are some of those terms we learned: prior authorization, quantity limits, step therapy, Part B versus Part D drugs. Okay. Oh, got a question here. Can't see that part. All right, let's stop sharing. And okay. So here you have your prior authorization, quantity limits, step therapy, B versus D. It explains that. I'll go back up. It explains the tiering, tiers 1, 2, 3, 4, 5. So it gives a nice little breakout. Here's the other thing. You don't have to memorize any of this information. If you're going through this with a client, you can just read it in order. All right. A lot of times you have to do it for compliance, and the client appreciates that too. Here we go. Utilization restriction exemption. You can ask to waive a coverage restriction, including prior authorization, step therapy, quantity limits. For example, for certain drugs, Humana Group Medicare plan limits the amount of drugs that we will cover. If your drug has a quantity limit, you can ask us to waive the limit and cover a greater amount. So that's perfect. Let's say it's normally a prescription that has quantity limits. Let's say you get 15-day supply, but you're in a situation where it's a maintenance drug for you, where you need to have a 30-day supply because you're going to be on it every single day. The utilization restriction would cover that. Tier exemption covers that. But let's scroll down and see what the actual formulary. Here's more dispensing limits, limited access. All right. So it breaks it out based off of the condition. Antibacterials, amoxicillin. Again, that would be a bit of what's the word I'm trying to think of? Antibiotic, something to that effect. Again, tier twos. Here's tier three, dioxycycline. So keep in mind, when we ask for this information from a client, we're going to ask for the name of the drug. I ask if that's the generic or the brand, because a lot of times people will use the brand name even though they're taking the generic. I'll verify that. I'll ask about the dosage. You see here, 500 milligram. The dosage is important. Also, is it a capsule or a tablet? A good example of why that's important is, well, it's actually not showing here. Sometimes the tablet or the capsules could cost more than the other. So you want to get that prescription as exact as possible. The other one is do you get a 90-day supply? Or do you get a 30-day supply? If we scroll down, antidepressants. You have tiers 1 through 3. Here you have quantity limits. You have ST, which means step therapy. Again, because that's a tier 4. So what was step therapy? Basically, they would want somebody to start off at maybe a tier 1, tier 2, or tier 3 before they got finally approved for this tier 4 prescription. Just randomly, we're going to scroll down. Cardiovascular. So you have amlodipine tablet, tier 1. Atorvastatin, tier 1. Anything different where it's the tablet? No, but here, if somebody says they take fenofibrate, that's not good enough because is it the 160 milligram tablet, which is a tier 2, or is it the nano crystallized 145 milligram tablet, which is a tier 3? So you really need to get the details here. Atorvastatin, 10 milligram, 20, 40, 80. The tablet is covered. So this is where you really need to drill down on the client. If you go to their house, it's nice because they have all their prescriptions there. You can actually read the labels and load them into the screen. When I'm working with a client, if it's going to be virtual, I usually have them email me all of this. I like to have it in writing. One, I'm a terrible speller. Most of my clients are terrible spellers too with these drug names. And I'm a little hard of hearing. So hearing, how to spell rosuvastatin instead of simvastatin, it's going to take me a lot longer. I usually have them email it. I load it in the system, and that way I can find out where they might have left off some information. Are you sure you're taking the brand name and not the generic? Can you tell me if it's a tablet or a capsule? So this is a good example of the formulary. I am going to share my screen because I want to go into Connecture and show the quoting tools. So just give me a thumbs up if the Pinnacle website popped up. All right, do you guys see the Pinnacle website? Perfect. All right, so you should all have access to this as long as you're contracted. So go to online enrollment, Connecture, or Connect for Insurance. Everybody must be on it right now. Choose Connecture. Everybody will have their unique login. All right, and I created a profile. You all can go on to Connecture, just and you can create a profile on yourself. Just don't go through the entire process of enrollment because this is a live system. So let's see, when was the last one I did? 7/30, 2025. So we're going to click on this. So when I'm talking to a client for the first time, a lot of times I'll bring up Connecture just so that I can get the information that I need. The first thing you need is the zip code. Why? Because CMS plans, the PDP and the MAPD, they're all broken out regionally. They're also broken out by county. So you need that zip code to figure out what plans are available. Get their first name and last name. If you want to fill in this demographic information, it's great because it will fill through to the enrollment system. So it's less work for you. You put in the Medicare number, their effective dates. We talked about preferences last time. You can add providers, pharmacy. Okay, I did CVS and ShopRite. Let's see what prescriptions I have added. Ozempic, that's an expensive one. Let's leave that. And I think the duloxetine is the generic of Cymbalta. Let me change that. Let me actually delete that so that you can see the difference between the two drugs. So let me add Cymbalta. See, when you're loading the prescriptions on here, it'll ask, hey, do you want to see what the generic for Cymbalta is? I'm going to choose no, and I'm going to add that. My drug list looks good. Subsidy. So if you don't know if anybody's getting extra help or LIS, you'll put I'm not sure. Okay. We're going to continue to the plans. So remember, we're looking at prescription drug plans. So we have the first tab, which are the MAPD plans that have the prescription drugs added. We also have the third tab, which is the prescription drug plans, the standalones. So the first thing I do is I sort by total estimated drug cost. So based off of those three drugs, this plan from United Healthcare, the 001, comes at the least expensive. I know right now that only two of those three drugs are in the formulary. Okay, I'm going to write this down, 001 UHC. The cost for the drugs estimated is $1,791. I know that. This plan has a premium of $79. And the total estimated cost, that's the plan premium and the drugs, it's going to be $2,107. So you always ask, hey, wait a minute, I thought there was a cap on that $2,000, that $2,000 cap. That cap does not include the premium. Okay. It only caps the cost of the prescriptions. So if you had a drug plan that was $300 a month, you'd be paying over $3,600 a year for that plan, not in addition to your prescriptions. If I went into the meat and potatoes of this plan, I'm going to view plan details. I'm going to go to prescriptions. All right, atorvastatin. Initial coverage, zero. Person doesn't pay anything. Ozempic, they're going to be paying $47. Okay. Now the Cymbalta, not covered. They're going to be paying $337 because it's not covered. Here, I can change the pharmacies. So right now I have standard CVS, which is a standard pharmacy. ShopRite was another pharmacy I put in there. That's also standard. Or if they went mail order, would that change anything? Not really. Everything just got multiplied by 3. Estimated costs. Again, let's see. This plan does have a deductible. Some Balta right now for mail orders can be $1,090. Let's see. They're going to be paying $70 a month for the coverage. And then if we look at this again in November, they don't pay anything because they're getting a 90-day supply. But then again in December, that Cymbalta, that 90-day supply is going to kill them at $1,000. So this is a nice thing too, based off of the effective date, January through August. Again, the earliest that we can get them coverage is September. So this is only showing us from September to the end of the year. So let's go back to what we saw. If we look at other plans, you can see how these premiums, there's some that are 0, some are 24. But the key thing is this total annual cost or this estimated drug cost. Now, if we go in back to subsidy, let's say they did apply for LIS. You click extra help from Social Security. Hit close. Let's refresh. And let's see what we got. Well, right now it got changed. Okay. The least expensive plan right now is this Aetna Elite PPO. Estimated cost is about $2,000, no premium. Let's show a better example. Let's go back to subsidy. Let's do you're not sure. But when you called the client, you said, hey, listen, you're Cymbalta. Are you sure you take the brand and not the generic? And they say, you know what? I do take the generic. We're going to hit that. Update the system. Here's that plan we were looking at. All right, the 001, $79 a month. Now all 3 of the drugs are in the formulary. Instead of their prescriptions being $1,700 a year, now they're down to $517. Okay, because that Cymbalta generic was in the formulary. Now, let's say at $517, that's the least expensive that they would be paying. In total, it's going to be actually, you know what? Let's do total estimated cost. If we did total estimated cost, this Humana plan would come out at the least expensive because they have a 0 premium. All of their prescriptions are in the formulary, and their total estimated cost is $564, $62. All right, let me write this down. So Humana PPO. If we then go to the subsidy and say, I am getting extra help, $561 was the least expensive. Let's see what the extra help does. Now the least expensive plan is this Aetna Elite. So we went from over $2,000 for the total cost. Then we dropped it down because we switched the Cymbalta to a generic, and that was 561. Now they're looking at total estimated cost for the year only $24. So you can see how important it is to verify generics and brands and to see if they have that subsidy. Now, this is the Medicare Advantage side with the prescription drug plan, the standalone. Total estimated cost. Let me just hit refresh. they would be paying $86 because they have that monthly premium of $15.40. And the drugs that they would be paying for the remaining part of the year, $24. Oh, Broker Academy. If we reversed engineered this, so we're saying that the most they would pay is $86 on the standalone. If we reversed engineered this and said they didn't get a supplement, I mean a subsidy. Let's see. So it goes from $86 to it went from $86 to $824. So that's how powerful that LIS is. 10 times as much without it. Now, let's change that prescription. Let's get rid of that generic, or actually, let me see, make sure I got that $824. Let's get rid of this generic and let's put the brand. Add. Let's do it. $2,844. So we went from $86 to $826 to $2,844. So this is really the tricky part when you're dealing with obviously the standalone prescription drug plans, but also the Medicare Advantage plans. The nice thing about the prescription drug plans are you don't have to worry about doctors' networks while you do with the Medicare Advantage plans. So you have to worry about the prescriptions, but you also need to worry about the doctors' networks with the MAPD. If you want to compare the MAPD to, let's see, 2582 is the least expensive MAPD, and 2,844 is the least expensive prescription drug plan. Usually, prescription drug plan standalones, your member is going to be paying more a year than if they were on a regular Medicare Advantage. So I know there's a lot of technical difficulty with this. I apologize, but there is good training on our broker website. Again, on the Canadian Med Store and Jesse Pito's talking about how to get the manufacturer discounts. If you do come across a situation where you can't find the drug in the formulary, reach out to Tracy or reach out to myself. One more thing, the more you do this, the easier it gets. Don't get overwhelmed. You're not expected to have all this information stored in your head. All of the systems give you those breakouts. So feel comfortable in the system where you put in a brand name, it'll say if a generic is available, did you mean the generic? So just pay attention to the screens, read the process, and you should be fine. So thank you for your time today. I hope it was informative. This will be posted on the agency website as well. If you don't have any other questions, good luck, everybody. Enjoy the rest of your day.
Thank you.
You're welcome.